Good afternoon, everyone. I just want to confirm as we begin that you guys can hear me loud and clear. So the panelists, can you hear me okay?
Yes.
Wonderful, thank you. Thanks to everyone for joining us. Good afternoon and welcome to our 7th installment of the COVID Ethics series. And with that note, I'll just ask you briefly as people are hopping on to please mute your videos and your microphones. Thank you. So welcome again to our 7th installment of the COVID Ethics series, Vulnerability and Dependence in the Time of COVID. My name is Bryan Pilkington, and I teach ethics at Seton Hall University in the School of Health and Medical Sciences, the College of Nursing, the Department of Philosophy, and the Hackensack Meridian School of Medicine at Seton Hall. For those of you who tune in every week and are returning, welcome back. For those of you who are new or joining us for the first time, sessions in our series address ethical questions that have arisen or intensified due to COVID-19. We've addressed issues including the balancing of safety and duties of care, when and how to reopen the country, exercising ethically, and maternal fetal health, among others. We've also run advocacy sessions thanks to the work of Kelly Freeman and Clara Chen. Our conversations are multidisciplinary and interprofessional, relying on the idea that challenging ethical issues are best solved by many of us from diverse backgrounds practically reasoning together. I hope that my conversation with our esteemed panelists today aids in your own thinking about these issues. I ask that you mute your microphones again and your videos as you join on today. And please send us comments through the chat feature or tweet them at us at our Twitter handle, SHU Bioethics, SHUBIOETHICS. COVID-19 has disproportionately affected vulnerable members of our communities, and the nature of the pandemic has left many of the societal mechanisms intended to aid the vulnerable less effective. I approach considerations of vulnerable populations from the perspective that we are all, at different times in our life and in different ways, dependent on others. I'm very happy now to turn to our first panelist. I'll introduce each of our panelists as we go. We'll then move to a question and answer session at the end, but please feel free to send any questions in via the chat or through Twitter as they arise for you. Our first panelist is Nancy Berlinger. It is a great pleasure to have Nancy on today's session. Nancy is a research scholar at the Hastings Center whose work focuses on two major themes: ethical and societal challenges arising from population aging, and the role of health practitioners, systems, and policymakers in the care and well-being of migrants. Given Nancy's work, she needs a little introduction, but I'm sure it's obvious to all why she's a wonderful fit for this panel, and I look forward to learning from and with her. So Nancy, do I have you on the line?
Yes, you do, Bryan.
Thank you so much for joining us. The first question for you is a big question, and it really is, given all the work that you've done in light of COVID-19, help us understand and think through ethical issues associated with vulnerable populations.
Well, first of all, I'm so delighted to have this opportunity to talk about vulnerability today. Together with my fellow panelists, it's exactly the right topic at this moment in the public health catastrophe that we are all experiencing in real time with COVID-19 and the consequences of pandemic coronavirus. So I think, and I should add that I'm also from New Jersey, so I'm doing my best to think about my home state where my mother lives, and to think about how this cashes out locally as well as globally and nationally. You know, how do we encounter these issues where we live? Because as Bryan said, this is about practical ethics, not just something that is done in an ivory tower setting or only in a hospital. So with respect to vulnerability, I think what we're seeing now, because we're getting data out of the pandemic and we're getting data that is breaking regionally, by state, by county, by neighborhood in some cases, we're seeing who is vulnerable, who is especially vulnerable to this pandemic. Did I lose the feed? Because it just went down on my end, I'm sorry.
we will get it right back up.
Okay, so I'll pause.
I think we are now back up. Can you see the feed, Nancy?
I can see the feed. Terrific.
Wonderful.
Okay, so I'll resume. Okay, so when we think about vulnerability, it's such a big word. But if let's think about New Jersey. Let's even think about northern New Jersey. This is clearly part of the hotspot of the greater New York area. New Jersey, Connecticut, New York City, the suburbs, all are clearly the hotspot in the United States. And then when we start looking at the data on who is vulnerable particularly vulnerable to COVID-19, we see in some cases these are populations who have dependent relationships to others. When we think about all of the tragic stories that we see coming out of nursing homes in New Jersey and in other states, we are seeing about the effects of COVID on a population that was vulnerable in terms of their health status, namely people who are frail enough to need total care, to be dependent on other people in everyday life. Dependency is part of the human condition. We are all dependent at different times in our lives, but some people, because they have dementia, because they have another health condition or particular disabilities, need care all the time. So when we think about that population, we are thinking about people who are both dependent and particularly vulnerable to this disease, highly contagious, a lot of vulnerability associated with being in crowded conditions, congregate living, and so on. Some of the same vulnerabilities that you see in jails and in meatpacking settings, for example, a lot of people close together. But we also we're reminded that vulnerability is something that is created socially. It's not enough to just talk about a group of people as being vulnerable or at risk as if they did that to themselves. We create vulnerability when we tolerate inequality. And that is what we see in the COVID-19 statistics. There is the situation of nursing homes, which is going to have to be unpacked. We're going to have to think about the conditions in nursing homes and also the underlying health of people who need nursing home care. And we need to do a lot of thinking about how we can improve nursing home care and other long-term care settings. But separately from that, we have vulnerabilities that are the result of inequalities in our society that we have tolerated. We see this in the disproportionate data concerning COVID infection and mortality among persons of color. We see this among low-income populations, immigrant populations, service worker populations. I want to turn this over to other panelists for more perspective on this. But I just want to leave with one thought from Dr. Fauci the other day, who mentioned, he said, if you call a worker essential, you have a moral obligation to protect that worker. And so that's part of what we're seeing here is, how does being part of an exploited workforce set you up to be vulnerable to under pandemic conditions?
Excellent. Thank you, Nancy. I mean, highlighting the already existing inequalities and how these are intensified is a very helpful point for all of us in thinking through this. Before we jump to the next panelist, I just wanted to push you a little bit and ask, given your work on the aging populations, if there's any sort of reflection from that perspective that you think is especially important here.
Oh, exactly. The United States is an aging society. Many of the other societies that we are comparing our COVID-19 response to, whether Germany, Canada, South Korea, Japan, are also aging societies. That tends to mean societies where there are more people over 60 than there are under 5, for example, just as a rough estimate. So in those societies, the issues related to aging and issues related to care are always linked. You're thinking about a large population of people who are interdependent, and some are going to be increasingly dependent. So you're always thinking about who needs care, who's going to need care, who provides the care, what are the conditions of care work, and so on and on. So these are going concern issues in an aging society. Now, when we think about COVID-19, we have an illness that all of the data tells us is especially risky to people who are older, and old means a lot of things, but it's risky if you're over 60, 65, but it's especially risky when you get into your 70s and in your 80s, and this is borne out by the mortality statistics. And these are for age-associated conditions as well as because a person may have other health problems. So when we think about our aging society, we should not just think that this is a nursing home problem. It's also a challenge for the very large number of older adults who live at home, which is the typical place where people live. So as we start thinking very cautiously about what it means to go from lockdown to reopen, and there's a lot of things that have to happen in between lockdown and reopen, we have to make sure that we are not abandoning people who we know to be at higher risk of infection and illness at home, to sort of say, well, you just take care of yourselves. You know, you just stay there in lockdown with whatever grocery systems you managed with your family and your friends indefinitely until there's a vaccine. That's not going to work. That is creating further inequalities. It's prioritizing people who are more able to be out and about in society. It's prioritizing workers over people who may be out of the workforce. We have to remember all of the people in a society as we think about how to move forward as a society. So that's one of the aging society questions we have to remember.
Excellent. Thank you. A very helpful perspective. And with that, we'll return to some of this during the question and answer session. But with that, I'm going to move to our second panelist, Ana Campoverde, who is the Executive Director at the Joseph A. Uanu Latino Institute. Ana, do I have you on the line?
Yes, you do, Brian. Hello, can you hear me?
Yes, thank you for joining us. And please, with my apologies, could you correctly pronounce the name of your institute at Seton Hall, since I just butchered it?
Of course. I am the director of the Joseph A. Unanue Latino Institute.
Thank you. It's a pleasure to have you on, Ana, and to bring your perspectives on vulnerable populations during COVID. A number of ethicists, sort of all sorts of folks from all different walks of life have been talking about resource allocation challenges. We usually hear things about this ventilator versus that ventilator. But I know you've been thinking about and done some work on other kinds of resource allocation challenges, in particular translation resources. So I was wondering if you could just share a bit about translation challenges with us, as I know they affect vulnerable populations.
Yeah, of course, happy to. But you know, first I want to say, Nancy, it is such a pleasure to listen to your expertise. And, you know, in terms of being the director of the Latino Institute, the majority of our scholars are first-generation college students and come from immigrant families. So I want to go from kind of starting big and then going into the translation services. So as Nancy mentioned earlier, vulnerable populations were already suffering in terms of inequality socioeconomically and health-wise. So here in the US, for the 60 million Latinos, the outbreak has just exacerbated the consequences for immigrants and low-income families. So we come from a collectivist culture, and a lot of us live in households with multi-generational family members. Those in the US without authorization, they fear going to the hospital could lead to their deportation. So they delay their care. And a hospital visit usually is an absolute last resort. Latinos are more likely to work in lower wage jobs in leisure, hospitality, and other service industries. And in these industries, employees are more likely to be underinsured or uninsured completely. And right now, during this COVID-19 crisis, only about 15% of the Latino workforce can actually work from home. So Latinos are disproportionately affected by conditions like heart disease and diabetes, which makes them even more vulnerable to the coronavirus. So while Latinos represent about 18% of the US population, they represent 26.9% of weighted COVID-19 deaths. And of all the states reporting COVID-19 related deaths, there are only 7 where Latinos are not disproportionately dying. So, you know, we can take New York as an example because it is, you know, the epicenter of the outbreak. So as of last week, the preliminary death rate for Latinos in the city, when adjusted for size and age population, is 22 per 100,000, while the rate for Caucasians is 10th per 100,000. And another way of looking at that data is Latinos represent 34% of the deaths in the city, but they make up only 29% of the city's population. And a lot of that has to do because 75% of frontline workers in the city, grocery clerks, train operators, janitorial services, they're all minorities, and they have no option to work from home, or they just can't afford, to take those unpaid leaves. And in terms of resource allocation, you said it earlier, we know that testing is scarce. States are competing for ventilators, PPE for healthcare workers are in short supply, and the healthcare industry is just being stretched by the number of COVID-19 cases. So in considering another significant factor, one of the big things that has come to my attention is language. So COVID-19 numbers, directives, guidelines and initiatives, they're changing every single day. But what do you do if you are one of the 35.8 million people, million Latinos who don't speak English proficiently? So imagine not speaking English and having symptoms severe enough to warrant a hospital visit. So across the country, most hospitals now only allow the affected patient in to minimize risk. So you're alone and you're met with a medical team that doesn't speak your language. And before the outbreak, an interpreter would come in and assist you, but now interpreters across the US are at home providing virtual services when possible. And demand is super high for interpreters, so you might have to wait until one is available to get on the phone. So your care is delayed and your language nuances might be lost in translation. And that is the reality for thousands of minority patients across the country. So this is not something new. In 2015, the Joint Commission found that patients with limited English proficiency experienced adverse health outcomes at markedly higher rates than English speakers. So those outcomes, again, only become amplified under the stress of the outbreak. Municipalities, state, federal legislators, they release new information every single day. And there is a delay in information availability for non-English speakers. Community organizations across the tri-state area and across the country have actually taken upon themselves to sift through all this information, translate it, and try their best to distribute it within their networks. So, hospitals and organizations are pivoting, but as Nancy said earlier, an outbreak is not an ideal time to create a working and efficient system. So how can a patient process and understand the information in such a stressful situation with no one around them and, with their health failing? So, a lot of public health officials have begun to speak about addressing disparities by opening more test sites in hard-hit communities, coordinating care, and very importantly, improving the communication so that people that don't speak English have up-to-date factual information and they're not relying on unreliable sources in order to figure out whether or not they should go to the hospital or how to even contact a health professional. So, again, like health and societal inequalities were already pre-existing, and this outbreak has just amplified those inequalities. And it's important that we start talking about it and that our leaders raise the issue, but it's critical that moving forward, when this is behind us, it eventually becomes policy. So I could go on and on about everything about this, but thank you, Dr. Pilkington, for including the Latino perspective in this very important conversation.
Thank you, Anna. Excellent examples. I mean, challenging examples, but they fit very well, and I think instances which exemplify what Nancy had highlighted earlier in terms of the pre-existing inequalities and how that is sort of intensified in light of COVID. One quick question, if you don't mind, before we move on to our next panelist, which is you mentioned the importance of policy changes, especially in a time of stasis, and now we're in sort of a more challenging pandemic time. But I know we have a number of students on the line from our Interprofessional Health Sciences campus, as well as around the nation. And our IHS campus has a wonderful student life organization run by Kelly Freeman, and they've done a lot of work. So they've done some advocacy work recently with some letter writing campaigns, and I know there are other things going on. Would you have any recommendations from your perspective for students who are interested in aiding in sort of equitable causes, or who are just interested in getting out this word, what they could do on a policy perspective?
Absolutely. There are plenty of grassroots organizations that are working for not just Latino minorities, but a various amount of different minorities across the tri-state area. And I'm happy to provide any names and resources. I've worked in the nonprofit sector a long time. And when I worked particularly within the healthcare industry, a lot of the times we would have visits to our local and state political officials. And, you know, again, these are organizations that offer a lot of volunteer opportunities. So I think anytime somebody has a platform, in order to use it for good, you know, and spread this message of these things need to change, I think is an excellent idea. But, you know, if anyone on the line wants any particular connections or, you know, recommendations for different organizations that are doing amazing grassroots work, just let me know.
Excellent. Thank you, Anna. And we will share those resources that Anna shares with us in our follow-up discussion board, a little more about that later on. And we'll also share that via our social media accounts. I was remiss, since Nancy mentioned that she is originally from Jersey. Anna, I think you're now a 3-time pirate with multiple degrees from Seton Hall and now running the Institute. So this gives me the chance to say, go Pirates. I'm going to move now to our next panelist, Tade Ayane. Dr. Ayane, are you on the line?
Yes, I am.
Excellent. Thanks for joining us, Tade. So for all of our audience, Tade Ayane is the director of the Office of Diversity and Equity at the Hackensack Meridian School of Medicine at Seton Hall University. He's done a good deal of work, both in terms of his undergrad, grad, and doctoral degrees on education, especially with underrepresented minorities and now underrepresented minorities as they matriculate through medical school. So Tade, thank you for taking the time to speak with us. And if you could share your perspective on vulnerable populations at this time, we'd be grateful.
Sure. Thank you. Thank you for having me. Really happy to be here to get a chance to talk about this. What I would say is that the way that I kind of look at it is from a problem slash solution. And one way that you could frame it is basically the two panelists that spoke prior to me. They did such a wonderful job of framing the actual problem that I'm just going to add a little to that and then move over more to the solution. And basically, I think the conceptual theme that you'll see in what I'm saying and in what the other panelists have said is that when it comes to COVID-19, many times the approach is to deal with COVID-19, but we can't deal with it by taking it out of its more historical context. So just to kind of continue that actual theme, a really good case study for that is the city of Chicago. So when you look at the COVID-19 deaths there for Black people within that city, about 70% of the COVID-19 deaths are from Black residents of Chicago, but they only make up 30% of that particular population. So that's an incredibly high number. A basic way to think about that is that they don't even make up half of the population, but they make up over half of the deaths. And so normally when people see that, a normal response is, we need to do something about that. You know, what can we do related to our hospital system? But there's another stat that you have to connect with that really opens everything up. And that is that way before COVID-19 happened, for a very long time, even to this day, the life expectancy of a Black resident of Chicago is actually 9 years shorter than that of a white resident of Chicago. So what that means is you live in that city, and you are probably going to die a decade prior to someone who lives in the same country, in the same city, about 45 minutes away. And so to understand that, then you have to look at all of the different social variables, kind of. So the way that you can think about it is you take everything that we've all given you in terms of all those numbers, and when you add it to the last thing that I said, really what that should help us to see is that a big theme about COVID-19 is that we're all waiting to go back to normal. But we have to realize that if you're a Black resident of Chicago, or you're Latinx, or you're from all these different vulnerable populations, normal was actually pretty terrible. And the only reason that we considered it normal is because that's the way that it has been for a very long time. And so really, if we want to address a lot of the disparities that we're seeing within COVID-19, we have to look at the pre-COVID-19 period and say, hey, what was wrong with our normal? And so that's a framing of the problem. I'd like to talk about, okay, so you see that. What can we do about it? What should our next step be? You know, sometimes we almost feel bad, like we see all these stats, and then when we get off the line, we go and make a sandwich, right? But we can't just do nothing. And so one way that we can start to touch some of what I talked about is I'd like to just tell a quick 30-second story about a conversation that I had with a student about a year ago. So a young female Mexican student came to talk to me, and she said, what do I need to do if I want to become a doctor? And I said, you know, you need the chem series, you need the bio series, you need to probably start thinking about your MCATs like literally tomorrow. You need this, this, and this. She was a sophomore in college, and I said, you know, by the way, it's going to be really, really hard. And when I get done telling her, she just started crying. And I thought, oh, maybe I was just too blunt about what it takes to become a doctor. And she said, you know why I'm crying? Because you're the first person in my whole life who I've ever asked that question to, and you just told me the answer. Everyone else, my family, my guidance counselors, even other people at this same school, when I asked them that question, they always said things like this: have you thought about being maybe like an x-ray technician? Have you thought about being a nurse? Basically what they were saying is they were looking at me as a young Latinx woman and saying, someone like you doesn't become a doctor, so let me save you the time and let me give you some things that would at least still put you into a hospital. She said, look, you're the first person that ever, I asked that question and you said, oh, you want to be a doctor? Yeah, you just do this, this, and this. Good luck. And my point there is that she was coming across something that in my field we call the minority tax, which means that when you're part of a group that has been traditionally marginalized, when you want to do anything, especially in regards to K through 12 education or post K through 12, what actually happens is you have the same set of barriers that anyone would have, then you have a special set of obstacles just for you. And so if you think about what I actually started framing, what is the actual solution? If we can provide people more genuinely equal access to higher education, then just trust them to solve their own problems. Just another quick 30-second story that I think will help tie everything together. I was born in Nigeria. My family came here when I was about 2 or 3, and we were really poor. And I remember when we first moved to New Jersey, I remember sleeping on a mattress directly on the floor. Then all of a sudden, one year we moved to this really nice neighborhood and I started going to a really good school system. Well, what happened was my dad had completed medical school, but he was going through his residency. And so overnight we went from living in one part of town to a drastically different part of town. And the lasting lesson that I actually took from that was the transformative power of higher education, which is that for my family, because my mom went back to school, became a social worker, my dad finished his residency and is now practicing as a pediatrician, all of a sudden, my whole family's life changed in less than one full generation. And so my view of all these problems that we have actually framed is that if we want to provide some sort of lasting relief to a lot of the disparities that we've been talking about, one way to do it, and one very direct route, is we need to provide more genuinely equal access to the educational system, starting all the way from kindergarten all the way through grad school.
Thank you, Tade. A very helpful sort of adding to the framing that's been laid out and highlighting, as our previous 2 presenters did, that the structural inequalities which exist are only intensified by COVID. And on a personal note, I was appreciative of the stories. I buy into the view that when we think about human beings, we ought to think about them through their narrative arcs. So I thought those were both illustrative and very helpful in thinking about what people might overcome and where they might begin. I know we're going to have a number of questions for you and our other panelists. I just want to get our last perspective on the table. So I'm going to move now to our final panelist, Emma Wansel. Emma, do I have you on the line?
Hi, so I'm Emma, and I'm a behavioral health clinician in Tacoma, Washington. And what that looks like in a pre-pandemic world is meeting with folks experiencing homelessness in either emergency shelters or at various encampments throughout the city. And kind of just going to continue to hammer home this point that the inequalities that already exist have been really, really exacerbated. Nationally, we see that people of color are overrepresented in the homeless population. This is true in Pierce County, which is where I'm located. So in particular here, we see that homelessness among Black and Native individuals is disproportionately high. And we know this isn't accidental, right? Like, it's the result of structural racism that's excluded these groups from equal access to housing, community support, and other opportunities for economic mobility. And as we've discussed, people of color are not only overrepresented in the homeless population, but they're also disproportionately affected by COVID-19, which we've already discussed. And we're seeing that as well in Pierce County. Our data is pretty preliminary, but we're seeing that 3 groups, Black folks, Latinx folks, and Native Hawaiian and Pacific Islanders appear to be affected by COVID-19 at higher rates. So I'm working with a population that doesn't generally get much attention or support in normal times. And as Nancy mentioned, this pandemic has highlighted these inequalities that we have been tolerating for a really long time. So kind of what that's looked like in my work is when we started getting news about confirmed cases in Washington, and then we look at the population of folks who are accessing our shelter services, we see that race and socioeconomic status aren't the only risk factors. So a lot of people at the shelter are older, and they're more likely to have pre-existing health conditions like diabetes or heart disease that make COVID-19 lethal. And as if like that isn't enough risk, folks are eating, bathing, and sleeping in a shelter that sleeps about 170 people a night. And that doesn't even count the folks who are wandering in and out during the day, just grabbing meals, saying hi, just kind of socializing. So in like a normal day at a shelter, it would be an accomplishment to like make it through 24 hours, staying like 2 feet away from anyone else. So like a 6 feet expectation, it was pretty unrealistic for us. And then by the end of March, we found out that we already had 4 confirmed cases of COVID, and that is with like pretty minimal testing done. So our agency, working along with the health department, had to move almost 60 medically vulnerable individuals into a local hotel. Our shelter also has closed the day center, meaning anyone without an assigned bed would no longer be allowed inside. So while this did allow people to appropriately social distance in the shelter and in the hotel, people who didn't have assigned beds, the place that you spend time at during the day is now inaccessible. And for a lot of folks, that's where you get your meals, that's where you take a shower, that's where you can wash your hands. And other public places where you can access those services like the YMCA or public libraries are closed too, meaning that you have like virtually no access to public restrooms. So, and our staff members are still working to like maintain like regular kind of bare bones shelter operations, but our supportive services team, so case management, our mental health providers are working mostly remotely. So if our clients have phones, they do their best to stay in touch with service providers. And if people don't have phones, we really have no way to contact them. And for a lot of folks, that has meant like falling through the cracks, and we don't even know where a lot of the people that we normally work with are right now. So particularly in my work, kind of, we're starting to see like this psychological impact of the pandemic. So there's like this fear and anxiety, of course, of like getting sick, losing loved ones. And then also folks who are experiencing like a really deep sense of like isolation and exacerbation of depressive symptoms, which I'm sure most people who are quarantining can relate to. And then we have to think about for folks who have gone from, you know, living in constant contact of 170 of your closest friends, maybe not, but then you're secluded in this hotel room by yourself, and you're given like strict instructions like don't socialize with anyone. You kind of just have to stay inside all day. And then even, you know, new things are kind of coming up every day. I was just speaking with someone a few days ago who told me like they've been feeling a lot more hypervigilant than normal, and they weren't sure why until they kind of realized how much they relied on using body language and facial expressions to like tell who is like a safe person. And so for folks who have PTSD, like how can you adjust with that hypervigilance symptom if everyone around you is wearing a mask? So there's been like kind of a lot of new things popping up that we're trying to manage day by day. And this transition has raised like so many ethical questions that we've kind of been trying to work through. And I'm sure I could spend like days discussing them. But kind of the most significant ones that I've been thinking about is access to testing. We already know that we don't have like adequate testing capacity. And so what does that mean for this population that, number one, doesn't have adequate access to healthcare in the first place? Or if they do, there's like a lot of medical trauma kind of surrounding those settings. And so how are we, like what ethical principles are at play like when we're allocating tests in a community? Like we just had our first like mass testing at the shelter yesterday. So besides that first kind of like testing of like 15 people, yesterday was the first time that we got like asymptomatic folks tested. But kind of the biggest question that's been on my mind is how we're going to move forward. What's it going to look like for service providers to reestablish relationships with people who've been unsheltered during the pandemic? People don't have a lot of reasons to put trust in service systems in the first place. And now many of them are experiencing this like collective traumatic event without getting even their most basic needs met. Like they don't have a place to wash their hands. And like my hope is that our community care and allocation of resources will change after this pandemic. That's my hope. But there's also a fear that we're going to be content to kind of just go back to this unjust system, and meaning that we have to consent to a structure that significantly harms people who are already unaccounted for.
Thank you, Emma. But, you echoed well a consistent theme through all of our panelists' presentations. There are structural inequalities which then are exacerbated by COVID, and just addressing concerns with COVID, though they're necessary, we're touching on the symptoms and not the underlying issues. I also appreciated in a similar way that you did with, as Dr. Ayane did, sort of adding texture to particular stories for all our folks from across the country who are on the line but don't have experiences as you do in particular of homelessness or persons who don't have a home to live in currently. So thank you very much for that. It's no surprise, Emma, I didn't quite get the introduction out. Emma has a master's degree in ethics, so it's no surprise that she asked sort of big, important ethical questions as she closed what she was saying. And that gives me the nice opportunity to extend those questions to all of our panelists. And I'd like to direct them first to Nancy Berlinger. So Emma, you had asked what are the ethical principles that are going to guide us now? And then you asked the really big and important question of how we move forward. So I'll put those both on the table, and I'll turn to Nancy and ask, Nancy, any resources you have, I know some have gone through the chat, or any of your reflections or thoughts in response to Emma's two questions would be welcome.
Sure. The Hastings Center back in March created an ethical framework for healthcare institutions, primarily for hospitals at that time, because we were focusing on immediate COVID-19 response and predicting that was going to be seen in the emergency department and the ICU. And so it's an ethical framework for healthcare institutions responding to COVID-19. And the principles that we extracted there from when healthcare workers have to think in public health and community terms, focused on the duty to plan, not waiting for a crisis to happen, but planning ahead, planning for the worst while hoping for the best, safeguarding vulnerable populations, including the healthcare workforce, which, as we've discussed, is very much a minority workforce, an immigrant workforce in many respects. And also providing guidance where needed. So those are issues around, say, triage and resource allocation. That has been a lot of the focus of medical ethics or healthcare ethics in the past few months. Now we've just issued a supplement to our ethical framework that reflects the kinds of conversations that people are having around the country. And I'm very happy to say that Dr. Hannah Lipman from Hackensack Meridian Medical Center was one of our authors. she and others have been saying, well, we can't just think about our own hospital, our own employees, and think, well, that's good enough. We really do have to think in terms of our communities, who is a community member, who is a member of our society, so that we are not siloing or isolating good ideas, but also we're not leaving anybody out. So a good example of the kind of conversation, now that we really know where we are with this epidemic and realize how bad it's going to be for a long time, we're already thinking ahead to a second wave in the fall, but also we also know that people who are recovering from COVID-19 have chronic illness, and we have exposed the merciless economic inequalities in our society. We can no longer ignore what an unequal society we are, and how that is manifested in health inequities. So some of the things we need to think about, and again, imagine the county you live in New Jersey. Imagine Bergen County, imagine Essex County, Passaic County, Hudson County, Union, whichever county you live in. There's a lot of towns in that county, but the virus doesn't care what town you live in. The virus is thinking only, for the next place the virus is going to live, the next human it's going to live in. And some of my colleagues in public health ethics have said, because this is human-to-human contact, this virus, it is of social importance to protect each other. So we think about, wearing masks by protecting each other and so on. But we have to protect each other in other ways. We have to safeguard each other. So maybe that means that the hospitals, nursing homes, hospice programs, home care agencies in a particular county or in a larger community for once meet together. We all know how to get on Zoom by this point, and say, okay, who needs PPE? How do we make sure this is fairly distributed so it's not the wealthier, better connected institutions locking up the resources, even if they don't mean to lock up the resources, but there's a habit that we may not see each other properly. So when Emma is talking about shelters, to say, well, what is the gear needed so that shelter workers can be protected, so that their clients can be protected. Another thing that I'm thinking about a lot, because I teach at Lehman College of the CUNY system, which is a majority person of color campus, working class population, exactly the kinds of issues that Anna and Tade were talking about. So it is already, my students were already heroic for figuring out all of the moves they had to make to get a college education. The digital divide is very profound. And one of the ways you see the digital divide is when people suddenly have to go online for, people who are maybe dependent on the computer center at a college. They have a phone, but they don't have broadband access at home. There are a lot of people in their house. So it's really challenging to say, how is my education going to work? We've heard a lot of conversation about how it works if you're at a residential college, but we also have to focus on the engines of what we hope, the promise of greater equality, the public colleges, the colleges that serve first generation students, often immigrant students, and to say, how will we not disadvantage them further if, as it seems to be, that colleges and other institutes of higher education are going to have to be largely online.
Thank you, Nancy. Very helpful comment. And we have a few of those resources which Nancy mentioned from the Hastings Center, which have been super helpful for many of us working in these areas. We'll have those on our discussion boards, and I'll flag those in a little bit when we wrap up. Also, thanks for highlighting the variety of ethical principles that are in play, especially the duty to plan. That seems like it might be a helpful principle to focus on, both in light of what Anna and Tade had mentioned and what Emma drew our attention to, of these structural inequalities that exist now, that have always existed and are now intensified by COVID. As we're looking toward the future, Emma's wonderful question of how we move forward, thinking about planning for those situations and getting closer to equity is clearly important. Given all that Nancy had laid out for us, I wanted to see if one of our other panelists, Anna, Tade, or Emma, had questions or had a further response or elaboration on what we've just heard.
This is Anna. I would love to elaborate on what Nancy said about, different organizations coming together. So one of the things I mentioned was that a lot of community organizations are taking it upon themselves to, when there is inequality to access information in other languages, they're kind of taking it upon themselves to sift through the data, translate it themselves, and send it out. But going back to the duty to plan, in the future, I have seen, or we've started to see, a couple of different organizations starting to work together and creating local government and community organization partnerships. The city of Baltimore, in collaboration with Johns Hopkins, actually just created a program called Juntos, where they're trying to work all together to get Spanish information out to the network. I know right here in New Jersey, Englewood Hospital has partnered with the Hudson County Pastor Association. So, coming from a Latino culture, we grow up a lot with Catholicism and Christianity within our culture. Church is very important to a lot of different, countries within South America and the Caribbean. So Englewood Hospital has actually partnered with those pastors to create a series of videos and a series of, things that they can put in the newspaper when, people go, that can be delivered to people's homes, that has up-to-date information and has, free telemedicine numbers for Spanish speakers. So I think that, as we move forward in the future and how we're going to move forward after this is just maybe rethinking and innovating on different kinds of partnerships. I think a lot of the times organizations tend to work siloed. So, like I work here and I work here and I work here and we don't touch each other, we don't talk to each other. But I think if anything, like this pandemic has forced us to talk to each other, because we need to share resources. We're in a position where there isn't enough. And if we're able to connect with someone who serves a similar population, or we can help fill in a gap, like that's what we have to do.
Yeah.
Thank you, Wong. That's especially helpful. Yeah, Tade, jump in.
Yeah, I was hoping to go right after that, because I think that number one, I think she's 100% correct. And in terms of what does that look like practically from a higher ed standpoint, I want to go back to something that Nancy said, which is that we create vulnerability when we tolerate inequality. And so a basic way to kind of think about that is, one thing that I've been looking at is how can we incentivize these higher ed places to start to reach out to these communities and to start to work with them. So for example, a really kind of interesting grant came to me about 3 days ago that I'm working on right now, which is to get money from this organization and figure out how to work with our community partners so that so I work at a medical school, so that they are actually impacting our curriculum. And the whole goal of that is to systematically help students to reconceptualize how they view themselves when they come out of our school. So that kind of underlying principle of how do we take the resources that are there and help them to start talking to each other, I think is going to be a real key piece going forward.
Excellent, thank you. And thanks for mentioning the medical school as well. So Tade works at Hackensack Meridian School of Medicine at Seton Hall, as do I, and Anna's at Seton Hall as well. So there's a number of resources at Seton Hall. Seton Hall, shameless plug here, does quite a nice job aiming to connect with the surrounding communities. So it's really helpful, and maybe even in some ways a little easier for us to see the dependence that we all have, given the association between an institution of higher ed and its surrounding communities. But what Nancy highlighted about the future challenges we're going to face, especially in terms of COVID-19, higher ed going online, all of these options, and sort of access to certain sorts of technologies. Anna referenced telehealth already. There's a lot and many resources needed that lots of folks don't have. So thank you, Tade, for highlighting that. We've got a few minutes left, and I want to just bring this back to Emma for a moment, since Emma asked that wonderful forward-looking question. I was curious if any of what's been said by our three panelists in response, or just your own reflections on the homeless population that you work with, have any of these ideas resonated? Have they been helpful in how you'll go through and think about the work that you're doing?
Yeah, I think like thinking about like the duty to plan specifically, So in Tacoma, Washington, where I am, we declared homelessness a crisis 3 years ago. And then that has been like the only policy movement that we've seen in affordable housing. And really nothing has happened since that. So like, where is that duty to plan? And I love this idea of recentering kind of community well-being, kind of pushing back a little bit against our rugged individualistic tendencies, and this idea of like what is our conception of the common good look like. And something that is like mind-blowing to me is that like my agency, which is like the largest emergency shelter in the city, kind of really didn't have like a big partnership with the health department until this crisis. And now our leadership is meeting with them every day and kind of planning moving forward what it looks like to care for this population. Which is, I hope, continues moving forward, but and unfortunate that it didn't happen because we were in our silos. Like, this is public health, this is, you know, homelessness, but they're intertwined. You know, like housing is healthcare. So yeah, moving forward, I hope to see that.
Excellent. Thank you very much. We've had a couple questions coming in through different routes, and most of them have been asking about what can be done moving forward. We've addressed this a bit, but I just wanted to give the panelists one more chance if there's anything in particular in a sentence or two that you think folks should take away and what can be done moving forward, especially for those who recognize the interdependence of all of us and the special and what needs to be done in response to structural inequalities which have been intensified by COVID. So I'll start with Nancy. If you can give us a 1 or 2 sentence takeaway for the folks at home writing in, that would be super helpful.
I think for those of us who think about ethics and health a great deal, I think it is moving from general references to social determinants of health to talking very explicitly about social inequalities that are embodied as health inequities, to be very, very clear about what are the sources of health inequities, and also the fact that people don't bring barriers with them. Those barriers are created. So I have learned in these past few weeks not to say, immigrants have barriers to healthcare. No, they face barriers to healthcare, whether homeless populations, other populations, really drilling down, when are we using jargon that intentionally or not disguises the problem? Because we have to speak very plainly, but we also have to offer a solution, not just wring our hands about problems.
Thank you, Nancy. Thank you. And the careful attention to language is most welcome. Anna, any final words take home for our audience?
I will definitely second what Nancy just said, but I think, in a couple of words is, at least in my perspective, is the intention to reevaluate and being extremely detailed in making sure that as we move forward and new policies are created and new projects and initiatives, we are actively taking these vulnerable populations into consideration, very, very intentionally.
Thank you. Tade, a final word for our audience to take home.
Sure. Yeah, I think that there are 3 words that we can think about more: macro, meso, and micro. One thing, so I'm involved with a lot of the curriculum, and one thing that we've been looking at is that when we talk to our students, what can be done? Many people just always talk about macro. We need policy change. Absolutely right. Okay, but then we need to also think meso. What can happen in my community right now? And then we need to think micro. What can I do to help to impact someone in this way today? And what I've noticed with a lot of people that I talk to is the conversation at a macro level is free flowing. You start talking about meso, the conversation gets a little quieter. Micro, it's like, what are we doing? And so the more that we can kind of connect these and build it down, and then build it back up, the more that we can find practical things that'll help us to have an impact today.
Excellent. Thank you. Emma, any final word as our excellent questioner this session?
Yeah, I think kind of echoing what folks have said and kind of moving forward in all of these realms is just like taking a look at like your own community and looking at like who's at the table when decisions are being made. And who could you be missing? I think it's really easy for us to kind of just overlook a lot of people because, we shove them out of sight, whether it's in shelters or nursing homes, and then they don't have a voice kind of moving forward. So if we, we are to change things, kind of making sure that people have a seat and a voice at that table.
Excellent. Thank you very much. Before we wrap up, and I want to tell you about some other things going on, thanks so much to Clara Chen and to Kelly Freeman, who worked, you'll see on the screen, one of the examples of our excellent advocacy campaigns run from students in our medical school that Tade had referenced. So you can always email ethics@shu.edu, and we can connect you if anyone's interested in this work. Also, both sort of widely and on a personal note, the Hastings Center resources have been super helpful for thinking through a number of these challenges. Nancy humbly mentioned them. She's the lead author on so much here. And for those of you who have found her work helpful, her book on workarounds is, has been very influential in my own thought. So I'd turn everyone to this. The website's at the bottom. And also, Nancy will be on TV later tonight in Jersey, since we've got a Jersey-centric show today. I believe it's NJ Spotlight. Is that right, Nancy?
Sorry.
I believe it is. So we've got Nancy on NJ Spotlight later, so please tune in. I know I'm looking forward to that. Also, a thank you. We've wrapped up a Nursing Appreciation Week. I can't remember if yesterday or today is the last day, but thanks so much to all our nurses at Seton Hall who work at Hackensack in Jersey and everywhere who are doing this excellent work. And especially thank you, a special thank you to Callie Fell, to Judith Lothian and Nancy Anella, and all those who have appeared on our show already. And a final note, a belated Happy Mother's Day to all the mothers out there, and a special Happy Mother's Day to my mother. As the son of an immigrant, this conversation has resonated very deeply with me, and I'm very grateful to my mother and to all mothers who do so much work. So please join us next week, May 20th at 12:30 for another session co-sponsored by IHS Bioethics and IHS Student Life. We'll have Dr. Samson Davis, author of Living and Dying in Brick City, as well as Casey Choi, Dean Kuntz, and Lynette Martins. So thank you all for joining us very much. Please connect with us, follow us on social media, and we look forward to continuing the conversation in the weeks to come. Thanks to all our panelists, and everyone have a good day, and please be safe.